Start the recording now. So welcome everyone to today's webinar, which is focused on communication strategies for frontline staff in times of crisis. If we go to the next slide. Just an acknowledgement that this webinar is presented by the Region 1 Disaster Health Response System, RDHRS, in collaboration with the Regional Emerging Special Pathogens Treatment Center. Both of these programs are funded by the Administration for Strategic Preparedness and Response within the Department of Health and Human Services. Next slide. So just a disclosure, everyone can read this and we'll have this on the webinar, but really this is really intended to say that the individual speakers do not represent or reflect the official policy or position of any portion of the United States government, and that the content in which we're covering today does not substitute any form of medical, professional advice, diagnosis, or treatment, and the information shared here should be adapted to each specific need. Today's webinar is obviously a little less patient-facing, which makes this easier, but want to make sure that we go through this and that our speakers have no affiliation or financial interest or relationships to disclose. Next slide. And so very, very excited to introduce our speakers for today. So I am Jen Shearer. I'm the Director of Emergency Preparedness, supporting Massachusetts General Hospital, Massachusetts Eye and Ear, and Cooley Dickinson Hospital. I am joined by two absolutely phenomenal speakers who I've had the pleasure of working with for the last 5 years. So today we have Colleen Delaney. Colleen is the Senior Director of Internal Communications for Brigham and Women's Hospital and Massachusetts General Hospital. Colleen has been a part of the communications team at Mass General Brigham for 13 years. Previously, she worked in communications for Dartmouth Hitchcock Medical Center in Hanover, New Hampshire, and was a reporter and managing editor for newspapers in Hawaii, New Hampshire, and Maine. Our second speaker is Catherine Kate Finaccio. Kate is a clinical nurse specialist for the Patient Care Services Office of Quality and Safety and Practice at Massachusetts General Hospital. Kate has been at MGH for 23 years, at first as part of a co-op patient care associate in general medicine and the emergency department, and then as a staff nurse in general medicine and the medical intensive care unit. Kate earned her master's in science of nursing as a acute care and critical care clinical nurse specialist and worked for 6 years in the cardiac medical step-down unit. In 2019, she transitioned into her current role. Kate earned her Doctor of Nursing Practice in 2023 with a focus on patient safety and adverse event review. Kate is presented on safety culture and pressure injury prevention in both internal and external and international forums. And so I think it goes without saying, we have a really phenomenal group with us here today. And so without further ado, if we go to the next slide, we'll go through just a few learning objectives and then we'll hand it off to our phenomenal speakers. So our goal for today's webinar is to understand key communication strategies that healthcare leaders can use to convey critical information and policy changes to frontline workers during crisis. Our second learning objective is to analyze lessons learned from past crises to identify best practices to ensure quick and efficient implementation of new protocols. And then finally, evaluation of communication tools and strategies that can be incorporated into emergency planning to improve information dissemination and discussion, and how these can be adapted to different healthcare settings. And so without further ado, on our next slide, I'm going to turn it over to our first presenter, Colleen Delaney.
Hi, thanks, Jen. As Jen said, I'm Colleen Delaney. I oversee internal communications for Massachusetts General Hospital and Brigham and Women's Hospital, and I'm excited to be here, so thank you for having me. Next slide. Just a little bit of background about Mass General Brigham. We're an integrated academic healthcare system. We care for 1.5 patients annually, and we have about 82,000 employees. I'm a member of the marketing communications team, which includes both internal and external communications, as well as social media, website, creative design, branding, and traditional marketing. And so as an internal communications team, we believe it's our role to tell the hospital's story and support our employees during regular times as well as during times of disaster and crisis. Next slide. This is one of my favorite quotes about communications, and I think it's really important, especially during an emergency. You can see this is me here, because we can have the best possible communication. It can be engaging and interesting and timely. Yet, just because we have written a memo or drafted a story or posted to social media or worked with members of the traditional media to tell the story, it doesn't mean that people have opened their email. And it doesn't mean that they've read the email, they've watched the news or clicked a Facebook link. And even if they have read or seen the information, really doesn't ensure that engagement, that they have that takeaway that we really need them to have. Next slide. So we found that emergencies and disasters are really where you can learn the most about what makes up a successful communication. For our team, the Boston Marathon is one that we learned so very many lessons, and we've since implemented them into our crisis communications plan. So you can see here what took place on April 15th, 2013. And while this timeline is very specific to Mass General, it is very similar to what other hospitals within our system and across the city did. So you can see here the timeline of the first hour after the initial bomb went off. We already had our first patient. We had received media calls, many, many media calls. Our incident command team was set up, and media was actually outside the hospital before we sent any kind of message to our staff. So when we sent that first message, it was very general, just that these explosions had been reported. We were treating patients. We had this emergency structure in place. So we were telling our staff that the right people were at the table and the right people were working on it. But we also had to tell our employees to stay at work because we were assessing staff needs. Everyone was needed at that time because we didn't have all the details and we might need help in any area of the hospital. But looking at this, I think you can see where we could have done better. It is really, really clear now that we should have sent something to our employees sooner. Twitter, Facebook, social media, they were all telling this story, and a lot of it was confusing, and a lot of it was very, very incorrect. So in this world where news and misinformation spreads very quickly, we should have simply said, there was an incident. We don't have all the details, but we promise to keep you updated, and here is where you're going to find the latest information in the future. And so we have put those plans in place since the Boston Marathon for the recent CrowdStrike situation, for IV fluid shortages, for building emergencies. We really work to get that message out immediately. This timely messaging also helps our emergency preparedness and police and security teams. I think people have really been trained to, if you see something, say something, which is great. But if we can help alleviate some of those phone calls and email reports, people are reporting to the people who are trying to respond to the emergency. So if we can send a simple one-sentence message that we know there's a situation, you don't have to keep reporting it, more details to come. It's just really, really important. Next slide. So for the Boston Marathon, we can really see where we could have done better, and we also see where we might have done it right. And I think one of the most important things we did when we gathered our HICS team together, our incident commander immediately just said, stop and check in with your loved ones. She told us, just take a minute, just a few seconds, let your family know you're okay, and tell your family that you're okay. And we received so many thank yous from staff that they really appreciated this reminder to check in from home, because I think they are just experts in what they do. And if you're in healthcare, if you're in any way related to the world of emergency preparedness, you're just that. You're prepared for the worst. But sometimes that focus and that work ethic, it comes with that singular focus, and then it leads to stress later on. So that type of reminder, just to pause to check in, we've really implemented that into most of our emergencies kind of moving forward. Next slide. So when things started to calm down and we stopped to take a good look at what worked and what hadn't worked, it was really clear that a few things needed to change. We knew we wanted to follow the rule of emergency preparedness, quite simply just be prepared for anything and everything. So enter templates. Since we're in New England, we're accustomed to bad weather. It's freezing here now. So we started there. We created memos, electronic board messages, intranet posts, and FAQs. And then all of that information really helped with the creation of social posts and messages for patients and website copy. Because as we all know, anything that's internal really isn't internal anymore. A quick photo, a forwarding of an email, and it's out for the world to see. So you always have to be aware that what you're sending to your team and your employees can very, very easily be sent out. And in our case, we'll be on the front page of the Boston Globe or on Channel 5. So consistency in messaging is really key. Next slide. So we made these templates for snowstorms and hurricanes and even tornadoes, which our area hasn't experienced, but that could be a possibility in the future. And we've really seen the damage and destruction that they've caused in other parts of the country when they hit a healthcare institution. Next slide. So we have standard language that can be put into any emergency message, and that really is just that the hospital is always open. And these paragraphs have already been vetted, they're approved, they're ready to go. So there is no delay in waiting to see, is this the right message? Does HR or legal or a physician need to review? And it also helps with, my personal favorite, group editing of a message, which takes a long time. I think for communicators, for people who see themselves as writers, this sometimes can be really difficult because we want to craft a message. We want to set the right tone, have the right beautifully worded message that will resonate with our staff. But the reality is time is of the essence, and we just need to press send. So we have learned that we really can save some of that more thoughtful writing for a follow-up or a message of appreciation. And so with these templates, we then expanded our thinking to, public transportation shutdowns, traffic gridlock, where perhaps patients can't get in and staff can't get home. We have outlined IT failures, active shooter cases, major electrical outages, flood, fire, and now we're looking at future scenarios, especially, hacking situations and computer IT problems. What do we do if systems shut down and a template isn't going to help because there isn't a working email? Next slide. What we didn't plan on was a global pandemic for something called COVID. But luckily, we had prepared for a possible case of Ebola. So it's another infectious disease that could have a major global impact. And the materials we had created for this type of possible outbreak were at the ready. We had travel advisories, we had outlines of talking points, we had a list of experts in the field who could do media interviews. We had a really nice outline of what we might need to do. So then we just had to do it. We had to fill in the blanks and update, but we were really, really glad that we didn't have to start from scratch. Because we were really busy. And here on this side, you can see what Mass General did just during COVID's first year. Next slide. So one of the most challenging things about COVID communications, and everything was challenging about COVID communications, but that it was new and the guidance and knowledge about the disease was constantly changing. So we were really forthcoming with our information, both internal and external. We had daily statistics, how many patients we have, what our units look like. We tried to make the materials as relevant to as many people as we could. If it was an email for staff, what could we take out and put on the website, put on social, put into patient messaging? We also shared whatever we created with other hospitals that needed it. And I think this is a really, really important point. Don't be afraid to reach out to others to see what they've done or find out if it's something you can use. We were happy to share videos. Our nursing teams had created really excellent, timely, really helpful videos. We shared them. We shared design flyers. We shared emails in case the language was helpful. I think we were lucky in a lot of ways. We had a team of internal and external communications that were dedicated to this. We had a graphic designer and photographers and videographers on staff. And I know many of the smaller hospitals have one person doing it all. So reach out, talk to your colleagues, share and accept whatever you can. Next slide. Another key to communications during crisis is to make your message as simple as possible. And also be aware that not everyone is English speaking. We have materials in other languages, and we also use graphics to help tell the story. So again, we were lucky to have medical interpreters on staff who could help with this, and we were lucky to have graphic designers. Next slide. But we were also really lucky because we relied on our staff to help tell this story. They were key to the communications process, and that's something we've continued with other disasters. Our employees are our biggest advocates and champions, and they're the people that our community turn to ask what's going on. How bad is this really? What do I need to do? How concerned should I be? And as a patient or a loved one of a patient, am I safe? And if we provide our staff with the correct information, they can help us do our job. Next slide. So we relied on our staff to tell their story in their native tongue. And I think it's important here to note that the photos and a lot of the videos we were doing at that time were not professionally done. They were done with phones. They were filmed by staff who did not follow our advice on how to hold the camera correctly, just despite constant advice. But we got it done, and that enabled us to get the information out really quickly. And we also had to pause and pivot on things like our intranet. We had built really nice pages with tons of information and photos and what we thought as communications team was really great information. However, our clinician told us that they didn't work for them. They wanted to have these, what we called the pageo links, many, many titles with hyperlink in blue, just lines of content. And those pages for people in communications and design, it makes us cringe, but they were the ones that worked for physicians and researchers and clinicians. So we need to not only provide our guidance and our expertise as a communications professional, but we also need to be really, really good listeners. Because a page can look great, but if you don't have the views and if you don't have that engagement, then it's pointless. So in the same way that communications these days can't be one thing, a single story on a website. The same holds true with how we are saying the message. So that one size definitely does not fit all. I want to mention quickly our intranet here because it's been a key part of our emergency response. After the Boston Marathon, we realized we didn't have a good spot for information. There was an outdated intranet, which was on Dreamweaver for 25 years. Departments had their own SharePoint sites, but we were really lacking in having one resource, one source of truth. So we created a new intranet, and we were so thankful that we concentrated on this during a time of non-crisis. So we had just introduced our new site, and we were working to introduce it, get staff to use it, and rely on it on a daily basis. So at Mass General, we went from 5,000 page views a day, which that was on a good day. That was pre-COVID, to 22,000 page views with a 6-minute time on page during COVID. So the thing we had built really became successful. Having a place where staff can turn, having information be immediately updated when needed, and having these pages where we had a tab at the top to translate into the language of your choice, it's just such a necessity in any kind of emergency. Next slide. So finally, one of my favorite ways to communicate staff is through humor. I think you have to know there's a fine line between funny and tacky, but we do our best to try to use humor as much as we can. Our staff quite literally deals with life and death matters every single day. So communicating with them about institutional mandates or yet another thing they need to add to their plate can be really tricky. Next slide. So for COVID, we tried to infuse some humor into our plea for people to wear masks because we were getting really tired of the same old wear a mask message. Just wear a mask, put a mask on, wear a mask. So we introduced this Massachusetts General Hospital, and we had a little fun with a serious message. So our staff really loved these, and they became really popular on social media too. We actually had staff reach out to us requesting these designs for their departments and their teams. And if there was a holiday coming up they wanted to celebrate, they were asking for those. You can see an Easter one there. The message was still there, wear a mask, but the message was just in a different vehicle that allowed us to make things feel a little fresh. Next slide. So we've used humor in a number of campaigns. We created a superhero campaign with graphics like this one and video messages about PPE and hand hygiene. It's the same message, clean your hands, sanitize, be safe. And when our system introduced a new flu vaccination policy that all staff needed to get a flu shot, telling healthcare professionals who know they need to get a flu shot to get a flu shot felt like we were just repeating the same words over and over and over again. So we had a little fun and we introduced a flu meme contest where staff were invited to create a meme and submit it, and they loved it. We had hundreds of submissions, and how you submitted your meme was to go to the intranet where we had timely, important information that they saw while they were there, including all the dates and times of the flu shot clinics. So the next year, thanks to the success of that campaign, we created a flu haiku campaign, and that one was also successful. And again, we were driving people to the intranet where the key details lived. So we found that just because a situation or a project is serious doesn't always mean your response to it has to be completely void of humor or lightheartedness. Next slide. And finally, just another favorite quote. I think simple and truthful is always best. And just one final thing I wanted to mention. We've found that documentation is key. Taking pictures, video, interviewing everyone during a crisis, having that archive to use in the future and to learn from to do better in the next crisis situation is just essential. So thank you. I am excited to introduce Kate, who will now share the next presentation.
Great. Thank you so much, Colleen. And as a frequent consumer of your communications, I'm so appreciative for everything that you do all the time to help communicate these important messages out to our staff. So my name is Kate Bonaccio. I work for the Patient Care Services Office of Quality, Safety, and Practice here at MGH. And if you go to the next slide, I just want to orient you a little bit because I know MGB is a big structure and it's hard to sometimes contextualize where MGH fits within that structure. And then, so this is just, it's a little bit outdated now. It's of July, and you know, our organizational structure is very fluid these days, but I just wanted to orient you to the complexities of our organization and to highlight that our chief nurse and senior vice president for patient care, if you just kind of click one little click ahead, is part of our executive leadership team and leads our department. So this is specifically nursing and patient care services. And throughout this, presentation, I'm going to refer to our department as PCS. Next slide, please. This is the departmental structure of PCS. And so you can see here that we have a number of associate chief nurses who report up to our senior vice president. And our associate chief nurses oversee the function of our 43 inpatient units, our emergency department, and our perioperative spaces. They have a huge scope, and our nurse directors, who report directly up to our associate chiefs, oversee staff of clinical nurse specialists, nursing practice specialists, staff nurses, and support staff. And you click ahead for me right again. Thank you. And then one more time. Thank you. Sorry, I added some animation here just to kind of keep it lively. But in addition to our associate chief nurse on the operations side, we also have executive leadership, associate chief nurse that oversees our ambulatory nursing practices, executive leadership in learning and development, in clinical support services, in our allied professionals, and in quality, safety, innovation, practice, and nursing research. And if you click one more time, that's where I land on this structure, this hierarchical structure here. But all told, we have over 6,200 non-unionized nurses within PCS, which makes us the largest department within MGH. Next slide, please. So over the years, as MGH, and MGB begins to grow, we've made a concerted effort to standardize and consolidate our communication process. As Colleen mentioned and highlighted some of our great resources, this has really been an effort to streamline communication, reduce email overload, and so we end up with a lot of these broad communications that you see here. So we have a couple of email communications, as you can see, our clinician and practice update, our today's vitals communication, and these are really aimed at providing high-level content that might be pertinent across the spectrum of staff to all the organizations within MGB. We also have a number of, if you go back one, sorry. We also have a number of internal facing websites. So we have our MGH Vitals page, which houses a lot of detailed information and serves as a warehouse for resources for staff. So it's great for, source control and making sure we have the most up-to-date information readily available to our staff. And we've had some real success in that and making sure that people are using the most up-to-date and accurate information. But we have found that sometimes with these new modalities, some important clinical information is not always appreciated by staff as these messages come out. So It's not always clear for some of the messages that staff receive, what exactly it is that the practice change is, or how is it going to impact nursing staff on the unit. Next slide, please. So PCS has had its own unique communication system for well over a decade that predates some of the communication systems we have in place now. The primary audience for these communications has always been the staff within PCS, though they're often shared broadly outside of the department as well. As the clinical nurse specialist for PCS quality, safety, and practice, I'm generally the person that works with subject matter experts to produce and disseminate these notifications. And I wanted to just show you a couple of our examples. The leftmost document is a practice update. So as the name implies, it's intended to convey changes in nursing practice or maybe introduce new policies or products that we might see. The middle document is what's called a practice alert. These are generally sent out in response to safety events with a goal of heightening situational awareness about the event and to convey any existing mitigating strategies or maybe new strategies that are being implemented in response to that event, all with the goal of preventing it from occurring in the future. And this work aligns with our mission of transparency and safety culture. And then the document to the right is a Tuesday takeaway, which we send out during our Joint Commission preparatory period. So these Tuesday takeaways always address Joint Commission risk and guide staff on how best to either prevent a citation or how to engage with a surveyor as they're coming to the units. And each of these documents has a standardized template. So they have consistent border color, their font colors are consistent, and the structure to each one of these documents is consistent as they go. Next slide, please. Sounds pretty simple, right? Well, yeah, if only anything was that simple. It's a very, drafting these documents is a strategic process, and especially when you're thinking about breaking down these beefy, complex communication issues or these, major practice changes into these consumable bites for busy clinicians. A lot of this is learned on the job. There's a lot of trial and error, sometimes we are successful and sometimes we're not in communicating our message. But in preparing for this webinar, I came across the World Health Organization's Principles for Effective Communication, and I thought it was a great way to represent, some of the now subconscious strategies I use when crafting these communications. And so I'm going to get into the details of each, but in essence, it's ensuring that the communication that I'm providing is accessible, actionable, credible, and trusted, relevant to those receiving the communication, timely and understandable. Next slide, please. So, topping the list of principles for effective communication is relevance. So, in order to ensure that messaging is relevant to an intended audience, it's helpful to understand the environment which staff will be reading and reviewing the content. Fortunately, having worked at Mass General for 23 years on a variety of units and still maintaining strong connections with frontline staff and leadership, I'm able to place myself into a position of the staff who will be consuming that message when I'm crafting that language. What's important to them? What else is happening in the environment that may take priority over the issue that I'm trying to convey? What are some of the barriers that staff may face when they're trying to implement the change that I'm asking for? What is that right amount of information to give them in order to get the buy-in, but not overwhelming with detail? Much of the content that I'm asked to disseminate in practice updates is far beyond my expertise. So I work closely with subject matter experts to ensure that the content of these updates is complete and correct, but also succinct. This often involves distilling messaging down from just to that essential information and then providing links or resources for more background. You need to be sure that the message is clear about the directive to staff in terms of what we're telling them they need to do, change, add, or stop doing. So on the right-hand side here is an example of a practice update that was sent out during our most recent crisis, the IV fluid shortage. This update instructs staff to change their current practice of priming IV transfusion tubing with saline in order to preserve our supply of saline. This is a practice that's pretty broadly utilized by nurses in many care areas and needed to be modified in a crisis, so it's clearly relevant to nursing practice. The update makes clear what is changing with a brief explanation of the rationale and then provides additional resources as needed. Next slide, please. Along the same lines, it's important to ensure that the message in the update or the alert is understandable to the target audience. The message must be concise, but with enough background and context for folks to understand the rationale for the change. For practice updates, we always provide a leading sentence stating what the change is as concisely as possible. I try to include a little bit of background information, but I often provide links out to static resource documents that people can use as primary sources or references. I'll often embed these links right within the update themselves because they're distributed by email, but because I know that they're also printed and posted on units, I try to put QR codes wherever I can. From a visual perspective, I try to limit the number of text characters. I supplement with images and graphs and pictures as much as I can. And color is used very strategically to align with the template itself and to draw attention to key points of emphasis. Prior to distribution, I generally have subject matter experts do a final review to ensure that in all the editing down of the messaging, I haven't lost or misrepresented that essential information. The update reviews this update here, reviews a new product that was brought into MGH in the setting of the IV fluid shortage. The information is concise and bulleted. There are links and QR codes to additional resources. And there's a large photo of the new product with color that's used to make connections between the content and the components of the bag. Next slide, please. Thank you. I know that staff on the units are incredibly busy. So as such, I always try to aim to ensure that these communications are clear about precisely what is changing and what staff need to do, stop doing, or do differently. These messages, especially when a practice alert, are used to increase situational awareness of risk and to convey strategies we have in place or putting in place to prevent the risk from occurring in the future. And both of these types of communications, it's important to be clear about what the role of the changes in the system and the staff nurse and what their roles are in risk reduction. This update reviews another new product that was introduced during the IV fluid shortage. It's clear about what is changing and outlines the steps the nurse must take when using this new product. Next slide. The timing for distribution of these communications is another critical element. First, as I mentioned, it's important to understand the relevance of the change and the notification to the current practice state. Where does this message fit with everything else that's going on in the clinical environment? Are staff ready to hear and receive this message? And if not, what needs to be done so that they are ready? Are there any confounding or conflicting messages that are being delivered at the same time? And how will this message square with the information that others are receiving? The timing of this distribution is also very purposeful. For practice updates, it's a tricky time to balance between giving folks enough time to have an awareness of a product or a change before that product goes live, to allow for some time for training if needed, but not send it out too early so folks forget about it by the time they actually see it. Practice alerts, depending on the severity of the event, we may send them very early just to increase situational awareness, or if we're trying to put together a kind of more complicated or a process that involves more buy-in from other entities of the departments, it may take a little bit longer before we send out those mitigating strategies. The Tuesday takeaways are sent on Tuesdays during our Joint Commission preparatory period, so staff will know that they'll receive one every Tuesday, and they'll cover a different area of risk. There's also quite a bit of strategy about when and how these messages are sent. So because of the sheer number of nurses we have within PCS, the ability to message directly to the nursing staff is limited to a select few, and I am not one of those people. So we, and in addition to that, the practices and the patient populations on all the units are very different. And so not all messages apply universally across the board. So what we do is we email our communications out to the unit leaders, who then distribute those messages, the ones that are relevant to their staff, out to their staff in a variety of different ways. So for example, many unit leaders send out a weekly email with all the kind of updates of the week and a summary of those key issues. And my practice updates and alerts are, it's a great vehicle for getting these practice updates and alerts out to staff. But I need to be strategic about when I send them to be able to get onto the email. So as a rule, I do my best to avoid sending anything on a Friday, though Jen's laughing because she and I have been in conferences on Friday afternoons trying to put communications together. But very strategically try to avoid that Friday afternoon send, because we know that those emails go out usually by Friday morning. And we don't want anything to get buried in somebody's inbox by Monday, at the time Monday rolls around. And lastly, I think Colleen mentioned this, it's a careful balance between giving your subject matter experts enough time to review and edit the content and actually getting that message out to staff. So I know that our subject matter experts are busy clinicians, and so getting the message out and finalized in a timely manner is this delicate balance of patience and persistence. Next slide, please. Because these communications have been around for over a decade, staff are accustomed to seeing them, and they know them as trusted and credible resources. In fact, when I introduce myself to staff nurses now, I often refer to myself as the practice alert and update lady, and then I apologize. But they're usually pretty gracious and appreciative. I know I've mostly talked about practice updates, alerts, and Tuesday takeaways, but we've also utilized a couple other mechanisms, such as COVID-19 updates. We use these during the height of the COVID pandemic. And as Colleen mentioned in her section, that information was changing so rapidly, especially during that initial surge, that these COVID-19 updates were often the primary source of initial communication with frontline staff. They just didn't have time to read the policy changes that were occurring so quickly. And these updates covered numerous topics such as changes in personal protective equipment and visitor policies, new ventilators, changes in our documentation standards, medication administration changes. I did quickly do a little review of my database, and it looks like I sent at least 84 COVID updates in the spring, summer, and fall of 2020. So it was a busy time for getting these out. We also have a newer communication type called a need to know. These notifications are directly delivered to staff, but they're intended to be fairly non-clinical in nature and broadly applicable across all of the PCS. They're not generated through our department, but we do work closely with those who are crafting the content and messaging. As I mentioned before, providing links to primary resources is really important, but also contact information. A lot of times these will generate questions, and so staff need to know where they can go to find more information. So whether it's contacting your unit pharmacist or contacting a specific person, we try to include that information in the update itself. And that helps with trust and credibility as well. Next slide, please. And then finally, these communications have to be accessible. So as I mentioned, the primary mechanism for distribution of these notifications is generally email out to nursing leadership. And my process is to craft an email to leadership with a very brief description of what that update entails, as well as the contact information for the subject matter experts, and maybe some other information that might not be relevant to the staff nurse, but might be important for the leader to know, usually around processes for implementation, or maybe some detailing around in-servicing that wouldn't really be appropriate to put on the update itself. And leaders can either forward these emails on to staff or put them into their weekly email blasts, or where I see them most often is posted and printed on the units. So this is one example I stumbled upon on one of our general care units, where they have a practice alerts board, and they hang relevant practice updates and alerts on this board. And this just helps to increase visibility. And then we also post these notifications on several internal facing websites, and this is just one example. And so just to summarize, these are the strategies that have worked within PCS. We're constantly growing and changing, and as we've become more of an MGB system, we're being flexible in how we approach these things, and of course always open to new suggestions and ideas, and happy to take any questions, comments, or suggestions, and feel free to connect with me offline as well. Thank you, Jen.
Well, first and foremost, just a tremendous thank you to Kate and Colleen, who are just both phenomenal speakers, but the wealth of information that has been shared in the last 30 minutes was both a trip down memory lane for myself as someone who's worked closely with both of you, but as well as I think speaks to both the complexity but the importance of emergency communications. And so we're going to transition into our question and answer sort of portion of this. And so highly recommend folks to submit into the chat or into the Q&A piece there so that we can benefit from Colleen and Kate's collective knowledge. While folks are sort of mulling over their questions, I have one that I'll probably start with Colleen. And, this was sort of an overlay to, I feel like, both of your presentations, which is how we balance accuracy and expediency, especially when there is a rapidly evolving situation. I think, as you had mentioned during COVID, we were, and by we, I mean the greater we and you and the team, right? We're obviously doing updates multiple times a day. And so would love to see if you have any recommendations in particular of how do you balance that expediency while ensuring the appropriate stakeholders are involved. I think we all know, especially during emergencies, there are many leaders that are going to want to be involved. And so how do you draw the line on the sort of minimum necessary subject matter experts in order to give information? Would love sort of any insights on how we've improved this process sort of over the years, recognizing it's probably, it's a bit of a science.
Well, I think it's always tricky, and I feel like as soon as we send something out, it's outdated and potentially incorrect. I mean, that's just the nature of kind of news and emergencies. I do think we have a good system in that as soon as we know that something's going on, we call the right people in the room, even if that's too many people, and at least to give them the heads up that something's going on, and also that they're going to need to look at materials. They're going to be we need to have them at the ready. And if they're not ready, who will they, delegate to take that on? So I think that's been really helpful of having people's cell phones at the ready and saying, I'll just text you as soon as we have it. So they're not continually checking emails and when they're trying to work on the real emergency part of it. But just having them at the ready as early as possible, I think has really sped that process up and the review process up. I think also making the emails a little more simple than we used to. We truly used to craft them as I don't know, a well-written document, and now we are understanding that bullets are the right way to go and just, quick and easy. So I think some of those things have really helped.
I think that that's super important, Colleen. And I think you mentioned in your presentation, leveraging templates and other types of things, especially early on when we know information is uncertain, just helps benefit that. And so I appreciate that. Kate, I think my next question would be for you. The need to knows, the practice updates have really, and others have really become critical vessels for how we share very clinician-facing information, whether it's a supply chain shortage, whether it's COVID, pick the sort of topic. For our listeners in for today's webinar, if they were looking to implement a similar practice, could you give just a little bit of background on how did we get this started here at MGH? And or if you were going back to your leadership to advocate for leveraging similar types of things, is there anything that you would say that you've learned over the years that would be helpful to, look at implementing similar processes?
So I would tag on to what Colleen even just talked about, of like knowing your stakeholders and making sure that you have the right people who are opining on what it is that you're sending. A little bit of that is trial and error. Like, I know I've definitely been in a situation where I've sent something out thinking it was about as perfect as it was going to be, and realized that I had forgotten how this might impact the emergency department differently than it would impact the general care unit. So I think initially ensuring that you're really thinking about the impact of whatever it is that you're communicating, to be sure that you have you've thought about those other areas other than the largest population of people. How is this going to impact your ambulatory colleagues? How is it going to impact the emergency department, pediatrics, some of those areas where it's a smaller population within the department, but they need to be considered, and maybe the message modified ever slightly. I will say that I was lucky enough to inherit the process of practice updates and alerts when I joined this department almost 6 years ago. They were already well established, and so I give a lot of credit to my predecessors and to my executive leadership for crafting that plan and honing it well over the years when I did pick it up back in 2019. So I'd love to be able to speak to the genesis of that, but I unfortunately wasn't involved at that point. But then I was a consumer of these products. So I already had an appreciation of the impact they can make, both as a staff nurse and then as leadership on one of the units. So I think to your question about, getting this process started, I think truly knowing and understanding your organization and the audience to your message is going to be really key in making it meaningful to those who are trying to receive it.
No, thank you so much, Kate. And I think to your points, not being afraid for that trial and error, making sure you know your stakeholders. And at the end of the day, right, if the language itself doesn't meet the needs of our frontline staff, right, we need to reconsider, do we have the right people in the room? And so really appreciate that. One question that was submitted from our listeners today, I'll sort of do open-ended and decide, Kate and Colleen, which one of you would like to respond and or both of you, which is they're asking if either one of you would be able to describe a little bit more around communications, how we've incorporated communication strategies into continuous quality improvement programming and compliance. So, like, for example, is there a design of action for alert flyers or other types of things? I think this is, from me, really getting at what we're talking about here is a lot of best practice, right, for how we share things in a way that ensures that we are really optimizing the way in which we are thinking about continuous quality improvement, both during emergencies, but also like just there's updates we have to share. So, Kate, maybe I'll turf this one over to you, but would love to hear about how we've leveraged these strategies into continuous improvements or continuous quality improvement
Sure. I mean,
programming.
I can speak to it a bit. We do use these in response to, serious adverse events that occur. And so, as I mentioned, the practice alerts are often used to, have that situational awareness piece or to make folks aware of the improvements that we put in place related to a serious reportable event. We also use our practice updates to talk about improvement strategies that have been implemented. We don't always cover the full content of, the why, the how, and like, here's our data, and this is why, we're implementing this. But we, certainly could provide that as additional background. I was just trying to look at the question again, sorry. So I will say too that we generally send these out by email, but if in the process of reporting a serious reportable event to the Department of Public Health, say for example, we do on occasion utilize these as part of our remediation practice after an event has occurred. So we sometimes will incorporate them into an online learning module where staff have to complete it instead. So rather than kind of more passively put it out to the masses, this is more of an active part of our remediation plan when a serious event occurs. So we do kind of use it in different ways. We also know that, as Colleen mentioned at the beginning of her presentation, just because it's put out there doesn't necessarily mean that people have received the message. So we're cognizant of that too, and know that communication or an education is a weak intervention when it comes to addressing an adverse event of sorts. But we will use these as vehicles for broadcasting stronger interventions that have been put in place as part of either continuous improvement or in response to an adverse event.
Thank you so much, Kate. I think that that's incredibly helpful. And I know a few folks have raised their hand, encouraging folks to submit any questions into the chat as we go. That definitely will help us sort of not only capture, but make sure we address everything. So while we wait for more folks to submit questions, and I think that that was a great one. Colleen, one of the things that I'd like to ask for your insights on is, thinking about our community hospitals, thinking about our health centers, thinking about some of our smaller institutions who may not benefit from having a larger team. A lot of the innovative solutions that you've shown, I think, really speak to the fact that these multimodal communication strategies to really reach our staff are so critical. And so I wonder if you have any recommendations about how to do more with less in some instances to sort of optimize, recognizing that the default's email and the default is sort of the internet. But would love to hear if there's any nuggets of knowledge that would be helpful on how we can really think about creatively sharing messages with our teams during times of emergency.
Yeah, so I think what we try to do is craft the main message, and then knowing that that might not speak to a smaller hospital, a non-academic medical center, or a community practice. So trying to just work with what they have it be the main message, and then perhaps highlight one or two questions very specific to that site, and that has been very helpful. Also, I think anytime you can use that hospital or that practice's people, so if we've interviewed someone that's well known, just say at Mass General, but perhaps not at one of our smaller hospitals, getting their counterpart there to have a similar answer. It could be the same answer, just coming from them. I think that helps with the trust factor too. So we just try to create that main message and then try to help them with just some of the smaller, oftentimes it's just adding two questions in very specific to that practice. So they're not reinventing the wheel. It's just adding on what hopefully will be helpful communications.
Thank you so much. And Colleen, I think this one is probably directed at a combination of you and me, actually, which, and Kate as well. So a little open-ended for all of us, which is a great question around how do you decide what messaging goes out to different modalities? And so the individual that submitted this, references, the fact that we can do Epic Day at the, whether it's an Epic best practice alert or message of the day, using systems like the employee alert system where we can ping staff on their, home devices, email, internal, intranet. Colleen, do you want to start a little bit with sort of saying how we think about internal triage? And then I'm happy to also comment a little bit on that as well.
Sure. I mean, I think it needs to go out everywhere. I think it's you don't know how people are getting their information that morning, that day. And so you have to send it out through the pager system, and then you have to follow it with an email, and then you have to follow that with a digital screen and on the intranet, and then even a sneaker patrol where you're getting out onto the units and talking to people personally. I think there's no best way to get information out. It's the best way is however the person is responding to it. So I just think in any emergency, we have our key places, the intranet and email. But following that, we have to go to practice updates, and we have to go to the trusted individual that those teams want to get their information from. So if it's getting information to managers and supervisors and having them distribute it, so it comes from their name, that's what we need to do. So I don't think there's any one best practice. I think there's no one best vehicle. I wish there was. It would make things a lot easier. But it's just really ensuring that we get all of those details to the right people to distribute and using all the vehicles we have.
Colleen, I think that's super important. And I think a piece that I would add to that is, is there an action oriented that staff need to take immediately? So, are there life safety and other types of considerations and actions that we need to take? And so I think that this, for the emergency managers that are on the webinar today, the way in which we think about, depending on the crisis that we are facing, if there are immediate actions that staff need to take, leveraging something like an emergency alert system that is able to ping all devices at once, that, really reduces the potential for patient and or staff type of safety issues. But Colleen, to your point, I think earlier as well, I think the multimodal sort of kitchen sink approach is also important though as well, even for prolonged and sustained events, because people all receive information in different ways to your note. And so it's not that it is necessarily there's a silver bullet, but rather mapping out in advance where you can, how and where we would use these is really important. And I think as Kate and Colleen described, we've used a variety of these to meet the needs. But I think this actually dovetails very nicely into the next question that's been submitted into the chat, which says, how do you get your communications team and leadership team on board with creating communication for times of crisis prior to the event happening? So I think that this speaks to how do we create templates and other processes and systems during quote unquote downtime? And so I'll sort of open up Kate and or Colleen, whoever wants to take that one first.
Well, happy to weigh in just quickly. First of all, I don't think there's ever really downtime in any of our fields, so it's trying to work around on the least busiest day. I think it's you have to make it a priority. I think if you read any news story about an incident that has happened anywhere in our country, it can help with that. I mean, for us with tornadoes, seeing them rip through a hospital and how quickly it happens when there is no time to plan, there are no messages being sent out. I think that really helped with driving that forward. I think active shooter cases and medical emergencies, cars crashing into buildings, just things that you see on the news and that you have seen happen in other places kind of can help your moving that forward to leadership and saying, hey, this happened somewhere, and I think we need to plan for it. In saying that, I also think those plans are already made at other hospitals, so or other healthcare institutions or emergency preparedness teams. So reaching out to other experts to see what they have so you don't have to reinvent the wheel, I think that's just really key.
I think that's spot on. And, as we think about the way in which we debrief, the feedback that we receive from our staff in real time about what works and what doesn't, Kate, you noted very appropriately timing and other types of things I think are essential. I think where we can pull from our lessons learned after the events help really set the justification for why we need to invest in this strategically as an organization. And I think that applies across the board for there. So I think, Colin, to your point, it's not only saying what is happening within our state or commonwealth, what is happening nationally, how prepared do we feel for those, but then as well as our lived experience, right? I think for the emergency managers on this who will laugh about this, right? Communications is always a positive, right? And one of the things we do well, and it's also one of the things that we can always improve upon. And so I think it's really leaning into that to say, all right, if we had to do this again, do we feel like we have done enough to really reduce, right, the challenges that we ran into before? And so I recognize we're heading into our final minutes for this webinar, and just a huge thank you again to Kate and Colleen. What I'd like to do is actually start with Kate and then Colleen and just ask for you both, any parting words for this group, recommendations, things that you wish you had known sort of earlier on, as you've worked through emergency messaging and other types of, rapid information sharing. So, Kate, I'm going to pick on you and start with you.
Um, Thanks, Jen. I think it's, the skill in being able to quickly deliver the information in a way that people are going to be able to receive it is so important. And so I think, as Colleen mentioned earlier in her presentation, it's not about the message you're sending, it's about the message they're going to receive. And so making sure that they're receiving, at least the concepts are aligned so that you're sending along the message that they need to receive in a way that they're going to receive it well. I think part of that is having some humility in your messaging, knowing that you're not going to get it right every time, but that you're going to learn from one opportunity for improvement and actually put that improvement into action, and one crisis and build on it for the next. So
Thank you, Kate. And Colleen, parting words and thoughts for this group.
I think just if you're in communications, you kind of are always failing before you start and after you start. It's always a learning opportunity, and you should look at it that way. And that there's always room for improvement. There's always room for growth, and there's always room to do it better next time. And just one other thing, I think appreciating staff and the people who are working so hard. Anytime you can get a message of appreciation or thank you out to teams, you should do it immediately.
Well, thank you both. For this just phenomenal presentation today and wealth of knowledge. As a reminder, this recording the session has been recorded and the slides will be available on the RDHRS website. Once we close out the webinar, this is just a reminder that everyone will be automatically logged out, so please don't be surprised by that. But again, just huge thank you to Colleen and Kate for this and for everyone's participation and fantastic questions today. We hope everyone has a great afternoon and weekend.